Hi, I'm Dr. Morgan Micheletti. I'm a cataract refractive and anterior segment surgeon at Berkeley Eye Center in Houston, Texas, where I'm also the director of clinical research. So I am a high volume cataract and refractive surgeon, and cataract surgery has more and more become a refractive surgery. So when my patients come to me for cataract surgery, they're not looking to just have slightly clearer vision. They're looking for more independence from glasses. They're looking for range of vision. And these are all things that premium lenses or advanced technology lenses can provide. What I like about the ClearView 3 is that it is different than a lot of our other diffractive technologies that provide similar range of vision. So the ClearView 3 is a bifocal, segmented bifocal, refractive optic that's not going to split light in the traditional sense that we're used to. And with that, I can allow my patients to see distance and near without the same side effects of massive halos or glare that patients may experience with other IOLs. They may still experience some other types of dysphotopsias, but that's all part of the discussion with the patient. The other thing I like about this lens is because it's not based on diffractive optics that can cut contrast, I find that this lens can work in more patients who have some mild pathology that otherwise may not be a candidate for multifocal technology. I've been using the ClearView 3 for over a year now, and what really got me interested in this lens was to have another option for patients who want to obtain bifocality or be able to see far away and up close without the same side effects of other traditional multifocal. So like any premium lens, it's important to have proper patient selection. With the proper patient selection, I have noticed, just tremendous results in terms of what patients are experiencing in regards to spectacle independence. I think the ideal candidate for a ClearView 3 is a patient who is looking for spectacle independence, but wants to be able to maintain the ability to drive at night with minimal dysphotopsias. For me, the astigmatism limits come down to what I'm comfortable doing an LRI for, and that's up to about 3/4 of a diopter with the rule and maybe half of a diopter against the rule. The ClearView 3 IOL is an option for patients in my practice who have minimal astigmatism, so less than a diopter, or they're not qualified for a toric lens, who also want to be able to enjoy life with minimal need for glasses, as well as be able to continue to drive well at night with minimal dysphotopsia. Some patients do experience some angel wing effect, but that seems to be in the lower portion of at least my cases and my experiences. So in over 8 million implants, there's been 0.0003% reported rate of incidence of calcifications with this lens, which is exceedingly low. And I think that's something that's not really understood nowadays by most of our surgeons, is that the hydrophilic material of today's day and age is different than that coming from the past. So just like in preparation for any premium lens, I absolutely polish the capsular bag. Occasionally patients do need YAG capsulotomy, but in my experience, it's no higher or lower than with any other lens. It's a very soft lens, and so it's pretty gentle on insertion. It slides right into the capsular bag, and it's pretty easy to position. I take the approach of a wound-assisted insertion, and so it's something that I don't need a second instrument for. It slides right into place, and then I can choose to orient it starting infranasal with the NIRAD, but then I'll start to position it so that my Purkinje reflex is just inside my distance portion of the lens. Well, the Holy Grail is no doubt a fully accommodating IOL. I think we're unfortunately still a ways away from that, given the current landscape. There's a lot of potential candidates for a fully accommodating IOL. There's a lot of regulatory hurdles to get there. So in the interim, we have to look at the options we have, and we do have a large variety of lenses, from diffractive continuous range of vision lenses to non-diffractive or a more refractive bifocal segmented optic like the ClearView 3, to extended depth of focus lenses that come in all different flavors, right? And with that, we have to make a decision that's best for our patients in marrying their eye to the IOL. So when considering different lenses for a patient, I think that a lot of patients will consider multifocal technology, and if a patient is concerned about glare or halos, they'll instantly jump to an extended depth of focus lens or to a monofocal lens. I think one of the considerations before making that jump to an extended depth of focus lens, if you're not already using the ClearView 3, is to at least consider it, because it does have a different profile in terms of dysphotopsias while still providing a range of vision for distance and near vision.